I have to be honest with you. Uh, when I first opened the file for today's deep dive, I actually thought I'd opened the wrong document. It looked like a complete.
Mess. How so? Like formatting or?
No, like it's this stack of lecture slides for a nursing course,
Hmm.
specifically Chapter 10, Emergency and Trauma Nursing.
Yeah.
But it's not just the typed text. It is absolutely covered in these frantic handwritten scribbles.
Oh, yeah, the student notes.
Yes, there are circles around words that are pressed so dark they almost rip the paper.
Mm-hmm.
Arrows pointing everywhere. Exclamation points next to things that seem totally random at first glance. It looks like the diary of a madman, or at least a very, very stressed out nursing student.
Which is honestly, that is exactly what you want. That is the best possible source material we could have for this.
Really? Because
Yeah.
I'm not gonna lie, it gave me a mild panic attack just looking at it. I was like, how are we gonna
Uh,
decode this?
No, it's perfect because in nursing education, you have the textbook, right? And the textbook is very polite, it's very sanitized, it tells you the official definition of things. But those scribbles, that is the professor stopping the lecture, stomping their foot and saying, listen, if you don't know this, you will kill someone.
Wow. Okay.
Or more pragmatically, if you don't know this, you will absolutely fail the NCLEX.
Right. The NCLEX, that's the big licensure exam, right? The absolute beast at the end of the nursing degree.
The big beast, yeah. And today's deep dive is essentially us trying to help you tame that beast. We are going to decode those exact scribbles. We're strictly following the learning objectives from this specific Chapter 10 to help any students listening totally nail this section of the exam.
And for everyone else listening who isn't taking a nursing board exam, we're going to look at what happens when the healthcare system is pushed to its absolute breaking point. Because it's fascinating.
It really is. We're talking about disaster. We're talking about chaos, but specifically controlled chaos. Emergency nursing isn't just about running fast. It is about thinking fast. It's about prioritization with a capital P.
Which prioritization it seems like a simple concept on the surface, right?
Yeah.
Just help the sickest person first.
In a normal world, yes. But we are going to talk about a world today where that logic flips entirely upside down, where helping the sickest person might actually be the completely wrong answer.
That sounds, I mean, it sounds wrong, just fundamentally wrong.
Uh-huh.
But let's put a pin in that because I know we're going to get to the heavy triage stuff in a bit. Let's start exactly where the notes start, the environment.
The emergency department environment of care.
Right. Now, I've been in an ER,
Mm-hmm.
hopefully not too often, but it just feels like loud, bright confusion, constant beeping. What are we actually defining here for the exam?
It's defined by unpredictability. In any other ward, say you're in oncology or med-surg, you generally know who your patients are. You know what they need. You have a schedule. In the ED, the doors slide open, and you have absolutely no idea what is coming through.
Literally anything.
Anything. It could be a stubbed toe, or it could be a massive gunshot wound to the chest, a cardiac arrest.
So the environment is basically defined by the complete lack of control over the input.
Exactly. And because of that unpredictability, the number one objective in these notes, and the thing that is circled, I think, about 3 times on the slide, is safety, specifically staff and patient safety considerations.
Yeah, I noticed that phrasing. It lists staff first. Staff and patient, that feels a little counterintuitive to the whole nurse as hero archetype, doesn't it? Shouldn't the patient always come first?
It feels that way emotionally for sure, but operationally, it's the airline oxygen mask rule. You know, put your own mask on first.
Right before assisting others.
Exactly, because if the nurse goes down, the patients do not get help, period.
If I pass out, I can't help the person next to me.
And it's even more acute in an emergency setting. Imagine a chemical spill in the community. Patients are rushing into the ED. They're covered in some kind of toxic industrial sludge. If you, the nurse, run out there to help them without your PPE, without your gear, you inhale the fumes, you touch the sludge, and now you are unconscious on the floor next to them.
And now the ER team have one less nurse and one more patient.
You have effectively doubled the workload and half the resources in 5 seconds. That is why the scene safety concept is drilled into every single first responder. You never enter a scene until it is secure.
Whether that's a shooting where the shooter might still be active, or a fire, or a biohazard.
Precisely. Competence is safety. Heroism in this context isn't running blindly into the fire. It's putting on the fire switch first.
Okay, that makes total sense. Now, speaking of fires and shooters, the notes make a really sharp distinction here between types of disasters. They break it down into internal and external.
Yes.
This feels like a classic vocabulary check for a test. Is this distinction really that important for the NCLEX?
Oh, it's huge. The NCLEX loves to give you a scenario and ask you to classify it, or ask for the appropriate nursing action based on the location of the threat. The response protocol is totally different.
Okay, let's break them down then. Internal disaster. The threat is literally inside the house.
The threat is inside the facility or right on the campus. The slides specifically list fire, flood, and shooting.
Okay, fire and shooting I obviously get. Those are immediate localized threats. But a flood, is that really common enough to be a top 3 example?
More than you'd think, actually. Think about it. Hospitals are massive buildings with incredibly complex infrastructure. Miles of pipes. If a main water pipe bursts on the 4th floor and the water starts cascading down into the ICU on the 3rd floor,
Oh, wow.
yeah, that is a major disaster. You have patients on ventilators who literally cannot be easily moved and water is rising around the electrical outlets. That's a nightmare.
I hadn't even considered that. So it's an internal disaster. What is your strategic goal as a nurse?
Protection and evacuation. You're trying to save the people who are already in your care from the building itself. You might be moving patients horizontally to a safe wing behind fire doors or vertically down the stairs, which, by the way, is incredibly difficult with bed-bound patients.
I can't even imagine trying to carry a hospital bed down a stairwell.
You don't. You use specialized sleds or you're carrying them. It's grueling.
Mhm.
So internal is all about getting the current patients away from the danger versus an external disaster.
Right. External means the event is happening out in the community. So the hospital building is perfectly fine, but the world outside is broken.
Exactly. The notes mention natural disasters like tornadoes, earthquakes, and then outbreaks.
And terrorism, or WMDs, right? Weapons of mass destruction. In an external disaster, the ambulance bay doors just fly open and the whole community pours in. So the strategy completely changes from get out to what? Get ready.
Get ready. This is where you activate the facility's emergency management plan. If you know a massive tornado just hit the local elementary school, you do not evacuate the hospital. You clear the decks.
Clear the decks, meaning what exactly?
You discharge anyone who is stable enough to go home. You cancel all elective surgeries immediately to free up the ORs. You open up overflow triage areas in the cafeteria or the lobby. You are essentially turning the hospital into a fortress to receive mass casualties.
That distinction really clears it up. Internal is protect the current patients you have. External is prepare for the massive influx of new patients.
Perfect summary. And that leads us perfectly into the biggest concept in this entire chapter.
Yeah.
The one that totally changes all the rules of medicine, the mass casualty incident, or MCI.
I see this term in movies and news reports all the time, usually right before everything explodes. But the lecture notes have a very specific equation written down next to it. It just says needs with a greater than sign resources.
Needs are greater than resources. That is the tipping point. And for the students listening right now, you must memorize that relationship. It is the absolute core of emergency preparedness. Needs exceed resources.
Walk me through that math. Because to a layperson like me, a bus crash on the highway with 20 injured people sounds like a mass casualty incident.
It definitely sounds like one to the public, and the news will probably call it one. But let's do the actual math. Let's say you're working at a major level 1 trauma center in a big city. You have 10 dedicated trauma bays, 20 specialized nurses on shift, 5 trauma surgeons waiting, and a fully stocked massive blood bank. A bus crashes.
Ah.
You get 20 patients.
That's a lot of people all at once.
It is a ton of people. But if you have the resources to treat them all simultaneously without compromising their care, that is not an MCI.
Really?
Really, that is just a really, really busy, stressful afternoon. You are still operating under what we call the standard of care. You are still treating every single patient as an individual who gets everything they need to survive.
Okay, so when does it actually become an MCI then?
When the math physically breaks. Let's take that exact same bus crash, but it happens in a rural area. You're working at a small community hospital. You have 1 ED doctor, maybe 2 nurses, and 3 bags total. And suddenly, 20 critically injured people are pulled up to your doors.
Oh, you literally can't treat them all.
You physically cannot. You do not have the hands, you don't have the ventilators, the blood, or the space. The needs, meaning the 20 dying people, drastically exceed the resources, which is your 3 beds. That is an MCI.
And that's when the philosophy shifts.
That is when you have to completely abandon the normal rules of nursing. In a normal standard of care situation, if a patient is dying, you do absolutely everything in your power to save them. You code them, you run a massive transfusion.
Right.
In an MCI, if a patient is dying and it will take all of your limited resources to save that one person, you might have to let them die.
That is chilling to hear a medical professional say.
It's the utilitarian principle, right?
Hmm.
The greatest good for the greatest number of people. And to make those impossible decisions in real time without totally freezing up, we use triage.
Okay, this brings us to Section 2 of our deep dive, the art of triage. And calling it an art feels like a real euphemism here. This feels like cold battlefield calculation.
Well, it comes directly from military medicine, so you're spot on. We use a color-coded tagging system. If you are taking the NCLEX or the ATI, this system is your bread and butter. You will absolutely get a test question describing a patient's vital signs and injuries, and you have to mentally slap a colored tag on them.
Let's go through the rainbow then.
Yeah.
We have red, yellow, green, and black. Let's start with red. Priority 1.
Red means immediate. The strict definition is life-threatening injuries, but, and this is the most crucial part, they are salvageable with immediate intervention.
Salvageable is a really key word there. We aren't just talking about the sickest people overall.
No, definitely not. We are talking about people who are dying right now, but who can be fixed fast. They require quick, high-impact interventions.
Can you give me a physiological example of that? Why does someone get a red tag?
Sure. Think about a tension pneumothorax. A patient has taken a massive blunt force blow to the chest, maybe hitting a steering wheel. Their lung has collapsed, air is leaking out of the lung into the chest cavity, and it has nowhere to go, so it's just building up pressure. That pressure starts pushing against the heart, physically stopping it from beating effectively.
That sounds fatal, like quickly fatal.
It is fatal, usually within minutes. The patient is turning blue, they're gasping, their blood pressure is totally tanking. They look like they are about to die because they are.
So why are they a red tag and not a black tag if they're about to die?
Because the fix is incredibly simple and quick. You take a large needle and you stick it right into their chest. A needle decompression. The trapped air just hisses out, the pressure releases immediately, and the heart can refill with blood. Boom, they are alive. You just saved a life in 30 seconds. That is the ultimate red tag. Extremely high return on investment.
Okay, that makes total sense.
Yeah.
Immediate threat, but a quick physiological fix. Now, what about yellow? Priority 2.
Yellow is categorized as urgent. These are patients with major significant injuries. But structurally and physiologically, they are stable enough to wait a short time for care.
Lecture notes say they can wait 30 minutes to 2 hours.
Right, and this is exactly where students get completely tripped up on exams. Because a yellow patient often looks significantly worse than a red patient visually.
Visually worse.
How so? Imagine a guy who is in an explosion and has a compound femur fracture. His thigh bone is completely snapped and the jagged bone is sticking out through the muscle and the skin. There's blood everywhere. His leg is twisted at a horrifying angle. He is screaming in absolute agony. It is gruesome.
Yeah, my human instinct is to immediately run to that guy. He's screaming. He's clearly broken.
But you have to suppress that instinct and check his vitals. Is he breathing on his own? Yes. Is he bleeding to death? Well, it's messy, but if the femoral artery isn't severed, he still has a strong pulse in his foot. His airway is wide open because he's screaming. His brain is getting plenty of oxygen.
So he's in horrific pain, but he's not actually dying this second.
Exactly. He is stable. He can wait 45 minutes for a tourniquet or a splint and pain meds while you go decompress the chest of the guy who is turning blue. The guy with the collapsed lung, the red tag, will be dead in 10 minutes. The guy with the yellow tag will still be screaming in 10 minutes. So the red always goes first.
Wow. It requires a massive suppression of basic human empathy. You literally have to walk right past a screaming person.
You do. You have to trust the physiology over the emotion. If you stop for the yellow, the red dies.
Okay, then we have green. Priority 3. The notes nickname them the walking wounded.
And that nickname is essentially a literal instruction. In a major disaster scene, often the very first thing the triage officer does is grab a megaphone and yell, if you can hear my voice, and you can move to that tree over there right now.
And anyone who gets up and moves automatically gets a green tag.
Automatically green. Because think about it. If they can stand up and walk, their airway is patent, their breathing is adequate, and their circulation is robust enough to power their major muscle groups. They might have a broken arm, deep cuts, bruises. They might be covered in dust and terrified, but they are not dying.
Why do we move them, though? Is it just to set up a treatment area for them?
No, it's mainly to get them out of your way. In a total chaos scenario, you need to visually clear the zone so you can actually find the reds and yellows. If you have 50 terrified people milling around crying and asking for help, you might completely miss the quiet, unconscious guy bleeding out under a collapsed wall. So you segregate the greens immediately just to clear the field.
Which brings us to the final category, the one that I think makes this entire topic so heavy. The black tag, priority 4.
Yes. This is the expectant category. It means the patient is expected to die or is already dead.
The notes list stiff, referring to rigor mortis, which is obvious. If they're already dead, they're dead. But it also explicitly says injuries incompatible with life.
And this is the ethical burden we were talking about earlier. In a normal ER setting, we fight for absolutely everyone. But in an MCI, if you see a patient with massive head trauma, and let's be graphic here because you'll see it in reality, brain matter is visibly exposed, their pupils are blown wide and unresponsive, and they are doing that irregular gasping breathing we call agonal breathing.
Right. In a normal, non-disaster setting, you'd intubate that person immediately. You'd rush them to the scanner and then to surgery.
Yes, you'd use a massive trauma team, a neurosurgeon,
Right.
a dedicated OR, and probably 10 units of blood. And even with all of that, they might still have only a 5% chance of survival.
But in a disaster,
In a disaster, you look at that massive resource cost. An hour of time and 10 units of blood, and you realize that in that exact same hour with those exact same resources, you could easily save 5 red tags who just have collapsed lungs or simple internal bleeding.
so trying to save the one black tag effectively means killing the 5 red tags.
That is the brutal math of triage. So you put a black tag on the patient with a severe head wound. You might give them some IM morphine if you have the time and the meds to make them comfortable. But essentially, you walk away. You leave them to die.
Even if they still have a pulse.
Even if they have a strong pulse.
That is incredibly hard to wrap your head around, let alone actually do it.
It haunts people. Nurses, paramedics, physicians, they carry those decisions home for the rest of their lives. But if you don't do it, if you let yourself get bogged down trying to miraculously save the unsavable, the total overall death count of the event rises. You fail the mission.
The notes mention a specific system called START to help providers make these decisions without totally freezing up in the moment. START.
Yes, simple triage and rapid treatment. It's a literal algorithm.
Yeah.
Because when your adrenaline is absolutely pumping and people are screaming, you cannot be doing complex ethical calculus in your head. You need a simple binary flowchart, yes or no.
And the chart scribbled here mentions RPM.
RPM, respiration's perfusion mental status. It's a rapid 3-step checklist. You do it on every single patient you come across who isn't already walking.
Okay, let's walk through it together.
Hmm.
You approach a victim lying on the ground. Step 1.
Step 1 is respirations. Are they breathing right now?
If the answer is no.
You manually open their airway, you tilt the head, back lift the chin. If they still do not take a breath, black tag. Move on immediately.
Yeah.
You do not do CPR in a mass disaster.
No CPR at all.
None. CPR takes a minimum of 2 people and exhausting sustained effort. While you are doing chest compressions on someone whose heart has already stopped, 3 people who just need a tourniquet will bleed to death. So no breathing equals black tag.
Wow, okay. What if you open their airway and they do suddenly start breathing?
Then they are a red tag. They have an immediate airway threat that required intervention. You tag them red, position their head so it stays open, and move to the next person.
Okay, let's say you walk up and they are already breathing on their own. What is step 2?
Perfusion. You check their pulse, usually the radial pulse at the wrist. Or you can check capillary refill. You pinch their fingernail until it turns white and see how many seconds it takes for the pink color to return. If there is absolutely no radial pulse or the cap refill takes longer than 2 seconds, it means their blood pressure is dangerously low. They are in shock.
So they get a red tag.
Yes, red tag. They are bleeding out somewhere, internally or externally.
And if they have a good strong pulse and good cap refill.
Then you move to step 3. Mental status. Can they follow a very simple command? You ask them, hey, squeeze my hand or blink your eyes twice.
If they can't do it, like if they're just staring blankly.
If they're confused, unconscious, or unresponsive, they get a red tag. It indicates their brain isn't getting enough oxygen or they have a severe traumatic brain injury.
And if they pass all 3, their breathing is under 30 breaths a minute, their pulse is strong, and they squeeze your hand perfectly.
Then they are a yellow tag. They are severely injured but physiologically stable, unless, of course, they can stand up and walk, in which case they are already over by the tree as a green tag.
It's just ruthless efficiency.
Yeah.
RPM. If you fail any one of them, you're a red. If you fail breathing completely, you're a black.
Correct. And for the exam, you have to apply that algorithm strictly. The examiners will try to trick you with emotionally manipulative details, like they'll say the patient is a pregnant woman or a young child. Do not bring your hospital heart to a disaster question. Stick to the RPM.
That is great advice. Okay, that is a really solid overview of the logic of disaster triage. Now let's transition and talk about the actual mechanics of injury. Section 3 covers trauma mechanics and surveys. The notes heavily stress MOI, which stands for mechanism of injury. Why do we as nurses care exactly how they got hurt? Doesn't the injury just speak for itself?
Not always. Knowing the mechanism of injury is crucial because physics tells a story. The energy transfer predicts the internal damage. If I know you were in a high-speed car crash and you weren't wearing a seatbelt, I know your body kept moving at 60 miles an hour until it hit the steering column.
Right.
So even if your chest looks completely fine on the outside, I know to aggressively look for a crushed aorta or a massive liver laceration. If I know you were stabbed with a 6-inch blade, I'm looking for a very specific localized path of damage.
The notes break it down into 3 distinct types of trauma: blunt, penetrating, and blast.
Let's start with blunt trauma. This is a massive impact without breaking the skin barrier initially. Car crashes, falls from a roof, getting hit in the ribs with a baseball bat.
What's the hidden danger here? Because bruise doesn't sound as bad as a stab wound.
The hidden part is exactly the extreme danger. With blunt trauma, the skin often looks totally fine, maybe a little redness or a mild bruise, but underneath, the kinetic energy has fully transferred into the organs. You could have a ruptured spleen that is actively bleeding 2 liters of blood into your abdomen. And from the outside, the patient just looks a little pale and complains of a stomachache.
So with blunt trauma, you really have to be a detective. You're looking for systemic signs of shock because you can't actually see the blood leaving the body.
Exactly. You are looking at heart rate, blood pressure, skin temp versus penetrating trauma. This is your knives, bullets, shrapnel. An object literally pierces the body cavity.
This seems a lot more straightforward. There's a visible hole where they got hurt.
It is more obvious, but you have to think in 3 dimensions.
Nice.
If a bullet enters the right side of the chest, where did it go? It doesn't always go in a straight line. It can hit a rib, shatter, bounce down into the abdomen, and shred the intestines. Yeah, you always have to look for the exit wound. And you have to assume that everything along that hypothetical track is completely destroyed until proven otherwise.
And then there's the third one, which ties right back to our disaster and terrorism theme: blast trauma.
Explosion injuries. This is by far the most complex type of trauma because it is what we call a triple threat.
A triple threat. Break that down.
First, you have the primary blast injury. That is the actual invisible pressure wave from the explosion itself. It moves outward faster than the speed of sound. When that sheer pressure hits the human body, it instantly ruptures hollow, gas-filled organs. So your eardrums blow out, your lungs pop, and your intestines can perforate.
You can't see that damage, but their lungs might just be shredded internally. That's terrifying.
It is. Then immediately following that, you have the secondary injury, the shrapnel. The bomb casing glass from windows rocks debris flying through the air at bullet speeds. That causes massive penetrating trauma all over the body.
And the third?
Tertiary injury. The blast wind, the physical force of the displaced air, physically picks the victim up, throws them across the room or down the street, and slams them into a concrete wall.
Which causes blunt trauma.
Exactly. So a single blast victim presents with shredded lungs, penetrating shrapnel wounds, and shattered femurs or head trauma all at the exact same time. It is a nightmare to manage.
So when a complex patient like that comes into the trauma bay, or really anyone in a trauma scenario, the notes talk about immediately performing a primary survey. This is the ABCDE approach.
Right. This is the absolute staying alive phase of trauma care. You do this in strict alphabetical order, and you do not ever move to the next letter until you have definitively fixed the current one.
Okay, A is for airway.
Simply put, is air getting in. If the patient is screaming at you or talking normally, their airway is open, you can move on. If they are unconscious and you hear gurgling, snoring, or silence, the airway is blocked. You stop right there and you fix it. You suction out the blood or you intubate them.
Once that's clear, B is for breathing.
The airway is a clear pipe, but are the lungs actually working like a bellows? Are they taking deep, even breaths? Is the chest rising equally on both sides? This is exactly where you would find and fix that tension pneumothorax we talked about earlier.
Because the pipe is open, but the lung is squished, so breathing is failing.
Exactly. You decompress the chest before moving to C,
which is circulation.
Do they have a pulse? And more importantly, are they bleeding out? If there is a massive pool of blood on the floor, you do not just note it. You put a gloved finger right on the artery, or you crank down a tourniquet to stop the bleed. You start 2 large bore IVs. You start pumping in fluids and blood to replace the volume they lost.
D is for disability.
This is a very quick specialized neurocheck. Are they awake? Are their pupils equal and reactive to light? Can they move all 4 limbs? We aren't doing a cryptic crossword or a full psychological evil here. We're just checking if the brain is currently online and getting blood.
And finally, E is for exposure.
You absolutely have to take all their clothes off. Trauma shears just cut everything off because you cannot treat what you cannot see.
Right, if they have the jacket on, you might miss a bullet hole.
Exactly. You roll them over, check the back for exit wounds, look for hidden burns or lacerations. But then, and the notes underline this multiple times, the second you finish looking, you must immediately cover them back up with warm blankets.
Why the heavy emphasis on warm blankets? They're indoors now, right?
Because hypothermia literally kills trauma patients. When a trauma patient gets cold, their blood enzymes stop working properly and they completely lose the ability to clot. So they will bleed to death from minor injuries purely because they got cold. So you strip them to check everything and then you aggressively bundle them up to save their life.
Okay, so strip to check, bundle to save. And only after all 5 of those ABCDE letters are stable do you move on to the secondary survey.
Right. The secondary survey is your comprehensive head-to-toe assessment. This is where you count their fingers, you check for a broken nose, you look for minor lacerations, you ask about their medical history. It's all the stuff that really hurts but won't actively kill them in the next 10 minutes.
So the golden rule is you never ever do the secondary survey while the primary survey is still incomplete.
Never. You do not stop to splint a broken finger while the patient is actively choking on their own blood. It sounds obvious, but in the chaos, people get distracted by the ugly, gruesome injuries. Stick to the ABCs.
I want to pivot completely now to section 4. We've talked a lot about physical kinetic trauma, but the notes take a really dark turn here into bioterrorism. There's a shocking amount of ink specifically spilled on smallpox.
Yeah, I know it feels archaic, but this is a direct reflection of the modern post-9/11 world. Bioterrorism preparation is legally mandated by FEMA for all hospitals. And smallpox is the perfect ultimate case study because it's a horrific disease that we successfully eradicated globally, but we absolutely fear it coming back as a weaponized aerosol.
The lecture notes are a bit chaotic in this section, but there is a very clear focus on distinguishing smallpox from chickenpox. It feels like a spot-the-difference game, but with apocalyptic stakes.
It really is, because chickenpox is a standard, somewhat annoying childhood illness. Smallpox is a total global emergency that locks down entire cities. The absolute key differentiator for the exam is the rash distribution.
The notes have a little hand-drawn diagram with the word centrifugal circled several times.
Centrifugal. It literally means fleeing the center. It means the rash moves away from the trunk of the body. In a smallpox infection, the lesions are extremely heavily concentrated on the face and the far extremities. So the arms, the legs, the palms of the hands, and the soles of the feet.
And chickenpox is the opposite.
Yes, chickenpox is centripetal. It loves the center. You will see the spots mostly concentrated on the belly, the chest, and the back, with very few on the far limbs.
So if a patient walks into the ED complaining of a fever, and they have spots all over their face and the palms of their hands, but you lift their shirt and their chest is relatively clear,
you hit the massive panic button immediately. That is a classic textbook smallpox presentation, and you assume the worst.
The notes also mention the specific physical progression of the rash itself. It says vesicular to pustular to crusting. But then there's this terrifying warning scribbled next to it. Keep scab covered, it can spread.
This is a massive vital safety point. With standard chickenpox, once the spots crust and scab over the child isn't really contagious anymore, they can go back to school. With smallpox, the live virus literally lives concentrated inside the scab itself.
Oh my God.
Yeah. If a dry piece of scab flakes off a patient and falls onto the hospital dead sheets, and a nurse comes in and aggressively shakes those sheets to change them,
The virus goes fully airborne.
exactly. The virus gets aerosolized right into the room. The patient is considered highly contagious until the very last scab has completely fallen off their body.
Which perfectly brings us to PPE. If you even suspect smallpox, what are you wearing to protect yourself?
The notes are extremely explicit here. Airborne precautions. Standard surgical masks are absolutely not enough. You need a properly fitted N95 respirator, the kind that seals incredibly tight to your face so you only breathe filtered air.
Just the mask.
No, you also need contact precautions, so gloves, a full isolation gown, and eye protection. But the N95 is the absolute non-negotiable test item. If the question asks for the priority PPE for smallpox, the answer is always N95.
And what about treatment once they have it? I see a mention of a 3-day window here.
That 3-day window is specifically for the vaccine. If we know you were exposed to smallpox and we can get the actual vaccine into your arm within 3 days of that exposure, it might completely prevent the disease from taking hold, or at least make the symptoms drastically milder. It's an absolute race against the clock.
And if you completely miss that 3-day window,
Mm.
they just suffer through it.
Then you are mostly relying on intense supportive care. 4V fluids pain management. There is one specific antiviral listed in the Scribbles, TPO-XX, or Tecovirimet. It is effective, but in a true mass bioterror event, global access and supply might be a massive issue.
I also see antibiotics randomly listed in the treatment notes. But smallpox is a virus. Antibiotics don't kill viruses.
Excellent catch. That is exactly why it's in the notes. The antibiotics are absolutely not for the smallpox virus itself. They are administered to prevent or treat secondary bacterial infections.
Because the skin is compromised.
Right, because your skin is essentially rotting and sloughing off massive amounts of standard bacteria like staph and strep can easily get into the open sores and cause lethal sepsis. You treat those invading bacteria with antibiotics, but you cannot kill the underlying virus with them.
Got it. That's a classic multiple-choice trick question setup.
Oh, absolutely. You'll see an option like the nurse administers penicillin to eradicate the smallpox virus. False. Total distractor.
Okay, we're heading into the final stretch here. Section 5 deals with special populations and mental health. Specifically, the objectives explicitly mention trauma-informed care, or TEC. This feels like a huge shift from the pure mechanics of trauma nursing to the psychology of it.
It's a massive paradigm shift in modern medicine. For decades, emergency medicine basically asked patients, what is wrong with you? What are your symptoms today? Trauma-informed care completely flips that and asks, what happened to you?
How does that actually change the interaction, though, in a fast-paced emergency environment?
Think about it this way. Imagine a patient comes in and they are being highly aggressive. They're shouting, maybe they're refusing to let you touch them to start an IV. The old school authoritative approach is to label them as non-compliant or a difficult patient.
Right. The immediate response is just sedate them or call security.
Exactly. Force compliance. But if you are coming from a trauma-informed perspective, you take a step back and realize this person is absolutely terrified. Maybe they have a severe history of physical assault or medical trauma. Being held down or touched by strangers without their permission is actively re-traumatizing them right there in the bed. Their aggression isn't malicious. It's a deep physiological defense mechanism.
So how do you practically handle it when you still need to treat them?
You slow down. You explain every single move before you make it. You say, I need to check your arm for a vein now. Is it okay if I gently touch your wrist? You give them back a sense of autonomy and control over their own body. And almost like magic physiologically, you will see their heart rate drop. Their breathing slows. They cooperate. It's actually vastly more efficient clinically than fighting them.
That's amazing. It's essentially practical functional empathy.
Yes. It prevents the hospital system itself from becoming just another source of trauma in their life.
The notes also heavily touch on homelessness as a very specific challenge within the ED environment.
Yeah, unfortunately, the ED is often the primary and only care provider for the unhoused population. They use it for everything from severe frostbite to basic medication refills. But the specific challenge highlighted in these notes is the discharge process.
This goes right back to the environment of care issue we talked about in the beginning.
Right. It's all connected. You can do a beautiful job setting and casting a broken leg. But if you sign discharge papers and send that patient out to sleep under a concrete bridge in freezing rain,
The cast gets totally wet.
the cast gets ruined, the skin underneath completely breaks down, they get a massive staph infection, and they are right back in your ER in a week with life-threatening sepsis.
So simply treating the immediate physical injury isn't actually enough. Social triage essentially becomes a core part of the nursing job.
You have to do it. You have to involve the social workers immediately. You have to find shelters, secure follow-up resources, maybe provide clean, dry socks. You simply cannot treat a complex injury in a total vacuum and expect a good outcome.
Wow. We have covered a truly massive amount of ground here today, from the stark utilitarian philosophy of disaster triage all the way to the microspecifics of identifying viral rashes. Let's try to really distill this down for the listener or the nursing student who has been furiously taking notes. What are the absolute key takeaways to lock in for the exam?
Let's hit the big ones hard. Takeaway number 1.
Safety first, above everything. If the nurse isn't safe, nobody is safe. Do not become a victim yourself, and know the stark difference between internal disasters like a fire where you evacuate and external disasters like a tornado where you prepare to receive patients.
Takeaway number 2.
The strict definition of a mass casualty incident. Needs exceed resources. Remember, it is a math problem. It's not just about a large volume of patients, it's when your capacity breaks.
Takeaway number 3.
Triage in a disaster is entirely ruthless. Red is immediate, but they must be fixable, like our pneumothorax example. Yellow is severely injured, but stable for now, like the open fracture. Green walks away to safety. And black is dead, or expectant, meaning unsavable with current resources. And the underlying logic there is strict utilitarianism, doing the most good for the most people, even when it hurts.
Correct. And to do that, you memorize the RPM checks for the START triage algorithm. Respirations, perfusion, mental status. If they fail any one of those 3, they are a red tag.
Takeaway number 4.
Bioterrorism, specifically smallpox. You must look for the centrifugal rash that focuses heavily on the face and the extremities. You must wear an N95 respirator mask because it is highly airborne. And remember, the vaccine is effective if given within that 3-day window of exposure.
And finally, the last takeaway.
Do not ever forget the human element underneath all this clinical protocol. Trauma-informed care is essential. Shift your mindset from asking what is wrong with you to gently asking what happened to you.
That is just, it's a lot to process emotionally. I keep coming back again and again to that mental image of the black triage tag. I mean, it's one thing to casually learn the definition for a multiple choice test, right? Black equals expectant. But it's an entirely different thing to genuinely imagine yourself standing over a real person who's looking up at you gasping for air, and you have to make the conscious decision to just walk away from them.
It is arguably the heaviest and darkest thing we ask of our emergency healthcare providers. We literally ask them to temporarily suspend their own deep humanity in that critical moment just to preserve the overall system, to act almost like a cold calculating machine so that the maximum number of people actually get to go home to their families.
But I guess that is exactly why the rigid training exists, why the algorithms exist, so that when that horrific moment actually comes, you aren't making life or death decisions based on your own panic or your own bleeding heart. You're just deciding based purely on the practice protocol.
Exactly right. As they say in the military, you do not rise to the occasion, you simply fall to the level of your training. That's why we obsess over these concepts. That's why we study the frantic squibbles in the margins of the lecture slides. It saves lives.
Well, on that incredibly intense but vital note, keep your N95s firmly fed, study your triage colors carefully, and we will see you on the next deep dive.
Stay safe out there.